Just try to memorize it. It means scaling. And rosea, like a rose petal, it means red. So this is a self-explanatory condition, that a condition that is red on the body and somehow it has a scales on it. This is known as pityriasis rosea. This is a very important thing. So it's a most of the time it's a self-limiting infection. It's a viral etiology, and many viruses are underlying cause of this condition. Many viruses. The pathognomic for recognizing this condition, what happens, a virus invades into your body, and the first lesion that develops onto the body is this one. This is known as Herald patch. Remember these terms, okay? So first of all, pityriasis, that means scaling, rosea means red, and the first lesion that is developing on the body is Herald patch. Many times when this Herald patch develops, many patients diagnosed it as tinea, because it has central clearing. Tinea lesion is exactly like this. So it has central clearing, it has this well demarcated border. Somehow this is scaly also. So most of the patient makes the diagnosis of tinea, and which is justified. Most of the time it looks like tinea. But what happens? It not resolving with the antifungal medication. And by the time 2 to 3 days passes and the patient develops shower of lesions like this. So initially there was only one Herald patch. The patient was misdiagnosed as tinea. And after 2 to 3 days, there is a shower of lesion, multiple lesions. And see the appearance of the lesion. It seems like a stem, and it seems like a this tree. So it's known as Christmas tree appearance. Its appearance is just like a Christmas tree. So pattern is like a Christmas tree. So this is a very pathognomic for the diagnosis of the pityriasis rosea. So what happens? This is exact cause we do not know. There are many factors. The most important one is the viral etiology. It can be your herpes virus, herpes 6, herpes 7 can be there. Any form of medication can be there. Your ACE inhibitor, NSAIDs, vaccination can be there, whatever. The most important, we correlated with the viral infection. So after some kind of illness, even with the upper respiratory tract infection, even with the some kind of flu-like illness. Patient takes some kind of medication, maybe NSAID, maybe some kind of blood pressure medications. Patient is vaccinated. Few days later, the patient developed this Herald patch. Okay, so what is this Herald patch? Herald patch is known as single oval pink scaly patch. This is the description. Single redness, erythema, and the scaly patch. This is known as Herald patch. This can occur anywhere on the body, trunk, neck, upper arms, most of the time upper body, not the lower body. So by the time the patient first lesion develop as Herald patch, after 1 to 3 weeks later, the patient develop lesions on whole of the trunk, which is known as Christmas tree appearance, Christmas tree pattern, just like this I have shown you. There is a stem and there is a different pattern of Christmas tree. So this is a typical distribution. And the condition resolve on its own with the 6 to 8 weeks. So this is the only little information about this pityriasis rosea. Very easy topic, caused by the viruses, initiated by the Herald patch, then subsequently develop Christmas tree appearance and resolves in a 6 to 8 weeks. If it's not resolving, most of the time nothing is required. Okay, you just counsel the patient that this is a self-limiting condition. It's going to be resolved in 6 to 8 weeks. You have to use moisturizer because the patient is so curious what's happening with me, and it's just spreads so fast like a Christmas tree appearance in the whole of the trunk that the patient becomes concerned. So most of the time you just give moisturizer. And if the patient is having some kind of irritation, you can use this antihistamine for itching or topical steroid to reduce the inflammatory factor. Otherwise, this is even not needed. Just emollients are enough. For the patient concerned, or if the itching is so severe, then you can use this topical steroid or antihistamine. If it's so severe, then you can use oral acyclovir. Why? Because virus was the etiology. Okay, herpes virus was the main etiology. That's why for the treatment you are using antiviral. Acyclovir is your antiviral. So that's how you are going to treat this case. This is a very beautiful picture. Very concise notes of the pityriasis rosea. Okay, so very good to learn. Okay, so it's self-limiting condition, just a Herald patch, Christmas tree appearance, and self-resolving. This much information is required. Then a very important topic are bullous disorders. What is bulla? What is vesicle? What is bulla?
Both are fluid-filled lesions, but
Excellent.
difference in size, I think.
Yes. Both are fluid-filled lesions. Clear water will be there inside it, and the that size will matter. So if it's less than 1 centimeter, this is known as vesicle. If it's more than 1 centimeter, this is known as bulla. So anything vesicobullous, we call the term as vesicobullous because it's not possible for most of the condition blistering disorder. The patient is just having less than 1 centimeter lesion. You are not going to measure it. So most of the time you see fluid-filled lesion, you call it as vesicobullous. Vesicles are there, bulla are there. So with zygobulous disorder, the important disorders are your pemphigus vulgaris, your bullous pemphigoid, and the third one is DH, dermatitis herpetiformis. We have done with the dermatitis herpetiformis. So now we are dealing with the bullous pemphigoid. So what is the difference between pemphigus and the pemphigoid? Anyone? There are very very few differences. Okay, if you are able to identify that, you are good to make the diagnosis. And most of the time in dermatology they can ask you the first line management, very very concise information, or they can ask you about the diagnosis, or they can show you some picture and you need to interpret it. Okay, so they do not go into so much details. AMC do not go into so much details of dermatology questions. So you should be able to identify how you're going to make the difference. This is pemphigus and this is pemphigoid. So very easy difference is that pemphigus is a flaccid blister, like loose blister, and the pemphigoid is the tense blister. Tense mean the blister will be persisting onto the skin for about 2 to 3 days, and the flaccid is going to be ruptured within a span of second maybe. So it's so loose skin or it's so flaccid skin that the patient's skin integrity is so damaged. Patient most of the time presents to you with the erosions, raw area of the skin. So this is the most important difference between the two. So if we go into the detail, it's an autoimmune condition, blistering disorder, both are. It is caused by the basically what happens, antibodies is formed into your body and it is attacking your skin component, and your skin component is known as desmoglein. This is just to make you clear what the disease is, but AMC do not go into the so much detail of these disorders. Okay, so desmogleins and this information is not required for you guys. So what happens, flaccid blister, this information is required. Blister, most of the time when you deal about the pemphigus, just note the differences. Whatever I'm telling you, this is a flaccid blister. Most of the time it presents with erosions. And the third important thing is that pemphigus always present with the oral lesions. Oral cavity is involved in the pemphigus, while pemphigoid most of the time do not present with the oral lesions. Okay, so these are the important differences between the two. So pemphigus, painful oral lesions can be there, flaccid blisters on the skin, erosions are going to be there. Skin look like a raw and fragile. This raw and fragile is basically the description of your erosion. Often it starts with the mouth because oral cavity is so much involved that often it starts in the mouth. Mouth is very important site for the pemphigus. Then it spreads to the scalp, face, trunk, any body site can be involved. But the clue for your exam is these things, these important points, that the painful mucosal lesions, flaccid bulla, positive Nikolsky sign, acantholysis. What is positive Nikolsky sign?
When you erupt the skin by your nail, it bleeds.
Bleeding, not really bleeding. Yes, somehow you are right. Bleeding occurs on the ospit sign. Remember, ospit. Ospit was your sign for the psoriasis. So psoriasis was when you remove the scale of the psoriasis, there is a bleeding from the underneath skin. This is known as ospit sign. Somehow Nikolsky is also like this, but this is not bleeding. Okay, so what is Nikolsky? It happens like whenever you have a blister, especially in pemphigus. As we are talking about pemphigus, is the skin is so fragile, the skin is so loose, so fragile, so it's not able to maintain the integrity. So what happens near the blister, if you apply a pressure with a finger, this is your finger, and you are applying a sliding pressure, sliding movement, you just start applying pressure from here to in downward direction or any direction. So what happens, skin was so fragile that the skin moves from that side and there is a erosion formation. Okay, so skin slides with your finger pressure and there is a formation of the erosion that is showing your skin is so fragile. So this is the definitive diagnostic test for the pemphigus. Okay, this do not happen in the case of pemphigoid, because in pemphigoid the problem is underneath the skin, in the dermis, in the deeper portion of the skin, not at the superficial layer. So your skin is not fragile at the moment, but in the underneath of the skin, the blister is going to be there. That's where the blister is tense. Getting my point? Got it? Or you want to revise it me?
Doctor, please repeat it.
Okay. So what happens? This is a blister. Okay. This is a skin. Your skin is so fragile. So what happens? Fragile means so not able to maintain the integrity. So loose. Okay. So what happens near the blister? You are putting a pressure with your finger. You are just putting a sliding pressure. From here, you are sliding the finger to this direction. So what happens? Your skin just move away. From here, your skin moves to this direction, and there is a raw area. Skin has just slide away from that side, and there is a raw area which is known as erosion. That is not possible for the normal skin to just move away with just a finger sliding pressure. If you just put a pressure onto your own skin, does it go away from its side? Never, because the skin is intact. Skin is just having maintaining the contacts. But here, the pemphigus, the skin is so fragile. The keratinocytes are not able to maintain the contact to each other. So whenever you put a pressure, the skin is just sliding from its original side, and there is going to be a erosion production. So this erosion is a confirmatory sign that your skin is not able to maintain the connections, and this is a patient of pemphigus. Got it? Not getting it?
Yes, doctor, thank you.
Okay. So this is a Nikolsky sign. This is very important. So in bullous pemphigoid, Nikolsky is negative. In pemphigus, Nikolsky is positive. So what are the main differences we have gathered so far? First of all, flaccid blister. Pemphigus is a flaccid blister. Pemphigoid is a tense blister. Second important point, oral cavity. Oral cavity is involved in your pemphigus, while in pemphigoid, no oral erosions is going to be there. Third important sign, Nikolsky. Nikolsky is positive in your pemphigus and it's always negative in your pemphigoid. So these are the three most important signs. Then histology, you will find some kind of intraepidermal blister. This is not important, just remember blister. For you guys, just blister is important. Immunofluorescence is also not important.
Sorry,
What is
ma'am.
the
Ma'am, the
yes,
test is positive in pemphigoid or
pemphigus, positive
pemphigus.
Nikolsky sign, pemphigus, okay?
Okay, okay.
Then they ask you about what is the diagnostic test, most important diagnostic test. Remember, the diagnostic test for any immunobullous disorder, whenever you are having blister on the body, the diagnostic test is biopsy with immunofluorescence. Okay. And if you have to choose one between the two, that would be immunofluorescence. This is a confirmatory test. Biopsy with immunofluorescence, ideally this should be the answer. But if they have mentioned both in the options, then immunofluorescence should be the confirmatory one. Initial is your biopsy. Whenever you are finding blister on the patient's body, initially you are going to do the biopsy. After biopsy, you are confirming your diagnosis by the direct immunofluorescence. So this is confirmatory, this is initial. So that's how you are going to treat it. And the treatment is just the corticosteroid. This is the most important one. Corticosteroid is the definitive treatment of pemphigus. So these are the very concise notes about the pemphigus diseases. Then comes the pemphigoid. Among the
Is
pemphigoid, the
it
most important one is
is it a
yes.
contagious or no? It's not contagious.
No. It's not contagious. All autoimmune disorders, these are not contagious. This is a autoimmune. Autoimmune mean your
Okay.
body own immune responses that acting against your own antigens. So that do not
Oh,
just spread from one person to another.
oh, thank you.
Next is your bullous pemphigoid. Okay, so bullous pemphigoid is very much alike to the pemphigus. Like it's also autoimmune, it's also blistering disorder, but now the bulla is somewhat deeper, subepidermal. Earlier it was suprabasal, like intraepidermal. This is your epidermis, then your basal layer, then your dermis. So pemphigus is just superficial destruction, so intraepidermal, inside the epidermis, and your that bullous pemphigoid below the epidermis, subepidermal. So these are the your sites of the blisters. Then the important thing is that in pemphigus, if you just compare the pemphigus, these are going to be the tense blisters. The patients are going to be elderly patients. This is very important. Pemphigus patients are young. These are elderly patients. Bulla remain intact for longer time because it was so tense. then skin is less fragile. That's why your Nikolsky is negative. Okay, skin is not fragile. You are not able to produce the erosion with a slight pressure. So Nikolsky is going to be negative. And the very, very important point, mucosa is not involved. It's uncommon. It's mostly spared. So this is very important point. So only if you are able to remember these information, you are good to make the diagnosis of this pemphigus and pemphigoid. This one. Okay. So whenever you find a painful mucosal erosion with a flaccid blister with a positive Nikolsky, this is your pemphigus. And whenever your patient is an elderly patient who have tense, itchy blister with a mucosa spared, this is your bullous pemphigoid. So these are the two very important lines. On histology, obviously subepidermal bulla because it was deeper. And in bullous pemphigoid, you have many, many eosinophils on your histology slides. Then again, immunofluorescence. This is the confirmatory one, and the treatment is same, steroids. Okay, so this much information is required. These are the three very important blistering disorders you need to remember for your exam. Bullous pemphigoid, pemphigus vulgaris, and dermatitis herpetiformis. Even you are not able to remember all of the information I have provided, just remember this slide. This is a summary, this is a take-home message. So anything tense blister which is itchy, this is your bullous pemphigoid. Anything flaccid blister which is erosion, sloughing is basically your erosions. Okay. Anything your erosions and your mucosal involvement, oral cavities involvement, this is pemphigus. And DH we have discussed yesterday that it was so itchy and it involves your extensors, your elbows, knees, and whole of the extensors is involved. So this is important one. Okay, DH, and the association of dermatitis herpetiformis, it's always with the celiac disease. Most of the time they give you scenario of the dermatitis herpetiformis like the patient was having some kind of blistering disorders on the elbows, knees, buttock, and there was a family history also positive. Maybe this can be distractor, or the patient was having some kind of abdominal pain, so that is showing that the patient is having celiac disease also, or the patient is having blistering disorder. So putting together, the patient is having DH, dermatitis herpetiformis. So that's how the patients are diagnosed. Okay. Okay. Any question?
Dr. Ushna, I think dermatology is a very hard subject because all the systemic diseases reflect on the
Yes,
derma
exactly.
side.
You cannot say
Derma.
that this is skin based that term. Okay. So
Thank
whole of
you.
your medicine is included in dermatology basically.
Ma'am,
That's the point.
can you please tell me the treatment of bullous pemphigoid?
Bullous pemphigoid and pemphigus vulgaris both are treated with the steroids. In immunobullous disorder, steroids are very important, but the second line treatments are different for both conditions. In your pemphigus, after steroid, we jump onto these immunosuppressive medication, azathioprine, mycophenolate, these kind of fancy medications. But in the case of bullous pemphigoid, after steroid, you give Dapsone. Okay, you prefer Dapsone or doxycycline even, tetracycline. Then you go for this immunosuppression medications, azathioprine, mycophenolate mofetil. But before starting these medications, you go for Dapsone and Doxy. Otherwise, the first line is for both is steroids. Steroids are important for those both management. Okay, so this
Doctor,
was
Dr.
yes.
Ushna, is there any relevance as far as acne vulgaris is concerned and this pemphigoid vulgaris is concerned?
No,
Is
no,
there
no.
any relevance? No.
Vulgaris mean common. Okay, vulgaris mean common. So anything which is very common of that particular disease, this is known as vulgaris. Okay, pemphigus
Okay.
vulgaris mean the commonest variety of the pemphigus, or acne vulgaris mean the commonest variety of the acne.
Acne. Oh, okay.
Yes.
Okay.
So
Thank you.
it's
Thank you,
just a
sir.
word. It's nothing else. Then we have a small topic of molluscum. We will do that also. Okay. So these are basically RCH guidelines, and this is molluscum contagiosum. Okay. This is a very important topic. So molluscum contagiosum, what you know about the molluscum? Most of the time they ask you about the diagnosis. Okay, molluscum is very important. They ask you about the diagnosis most of the time. So molluscum, remember, it's also a viral infection. Just we did the herpes simplex with herpes zoster. These are viral infections. So molluscum is also your viral infection. Molluscum contagiosum. And to remember it, it most of the time they ask you about this. They give you picture and they expect you to make the diagnosis. So you should be able to just clearly visualize this picture, make a mnemonic into your memory, visual memory. Okay. So molluscum is a bump. This is like a papule, but see, every papule has just central umbilication, just like a you have put a finger into inside the papule. It's like that. So central umbilication. This is a very very important point for the molluscum contagiosum. Just remember this picture as such. Every papule. See, it seems like a central umbilication. So these are the very very important points. Central umbilication is going to be there. Not in every lesion. Maybe some papules can be there. See, this is a papule, but you will be able to identify most of the lesion, the umbilication area. You're getting my point. This umbilication is very very important for your diagnosis of molluscum contagiosum. So it's a viral infection most of the time. The important thing is that it spreads from person to person. It's contagious because whenever you have an infection, anything bacterial or viral, this is always contagious. So viral infection is contagious. So important thing is that you have to counsel the patient that they should avoid bathing, that sheer towel or clothing. This is very important. Otherwise, it's going to spread from person to person. It's contagious. This is also known as water warts. This term is very important, water warts, because it seems like a small bump, like a warty growth, but there is inside a water. Okay, there is going to be a small collection of the fruit, which is not really a water, but it seems like a sometime a collection of the material secretions inside a papule, which has a umbilicated appearance. So this is known as molluscum contagiosum most of the time. How you are going to treat it? Most of the time, three MCQs are from this topic. That what is the diagnosis? They will give you a picture and ask you about the diagnosis, how you are going to treat it, and is it contagious or not. So this is contagious. Most important thing is that. Second is is it going to be resolved on its own or not? It's very important. So important thing is that molluscum can take time longer to heal, but it can heal on its own. It can take time longer to heal, but it can heal. Okay, so it can take up to 18 months, or it can take very long time to heal. Up to 1 year, it can take time to heal. So it's very very important for the molluscum. And the important thing is about the treatment, how you're going to treat that patient. So counseling is very important. This one. Do not let shared baths or towels with other children, dry parts of the body without